At this point, the classification we'll take a look at is primary CNS lymphoma. This is the first time that we're dealing with the lymphoma in the brain. The classification thus far that we've walked through have been primary CNS tumors, including our astrocytomas, under the category of neuroepithelial tumors. And then after astrocytomas, we walk through oligodendrogliomas, ependymomas, and so forth. So here we have a lymphoma. What does a lymphoma mean to you? It means that the lymph node in the brain is being affected. Accounts for 1% of intracranial tumor, 1%. Most common CNS in what kind of individual? Think about an HIV patient, or in other words, immunocompromised patients. That's extremely important. In fact, we have perhaps even diffuse large B-cell lymphoma that may be taking place in your CNS. And if you remember from WBC pathology, that whenever you talk about lymphomas, you're dividing this into Hodgkin's and non-Hodgkin's. And under non-Hodgkin's, if you remember, those are the ones that love to actually be extranodal. Most common presentation is altered mental status or behavioral change, and you'll have high-grade B-cell neoplasia. Once again, diffuse large B-cell lymphoma is something that could be found in these immunocompromised patients. Our topic here, ladies and gentlemen, is a primary CNS tumor, but this is of the lymphoma variant. The major clinical pearl here is, think HIV or immunocompromised patient, unfortunately. The clinical features of your lymphoma: deep gray structure, white matter, multifocal lesions are common, diffusely enhanced on MRI, diffusely enhanced. The reason I say that is because on MRI, you have another description that you want to know in pathology called ring enhancing. But this is lymphoma, so therefore it's a diffusely enhancing. Now, remember, there are different routes of metastasis. You could take your hematogenous route, which are most likely sarcomas. You could take the carcinomas would take the lymphatics, but with the carcinomas, we've talked about a bunch of exceptions. And the third route of possible metastasis would be seeding. What does seeding mean to you? It means that these neoplastic cells are then metastasizing to the adjacent structure, right? So seeding into the CSF is once again common. We've talked about this a few times with seeding. For example, I'll bring this to your attention so that your thoughts are organized. The most common brain tumor, primary brain tumor in a child, is a medulloblastoma. There's every possibility that the small blue cells may then seed into the CSF. And glioblastoma multiforme, one of a common adult type of primary CNS tumor, may seed into the CSF. Is that clear? Can also spread to the eye, this particular CNS lymphoma. Well defined with central necrosis, treatment, well, chemotherapy with or without radiation, and corticosteroid treatment may melt lesions, quote unquote. We leave the brain behind, and now we go into the cella. Now, normally, what do you have in your cella? We have the pituitary. So here we'll talk quickly about some pituitary adenomas without going into great detail as to the endocrinology, because that has already been covered. May present with endocrine neurologic manifestations. Think about the pituitary gland. Think about what you have superior to it, and obviously you are then going to compress the chiasm. May result in bitemporal hymenopsia. May result in headaches, right? May have visual issue, bitemporal issues. Most common endocrine presentation might be hypopituitarism. Be very careful with an adenoma, please. What do I mean by that? Because as soon as you hear an adenoma, do not think that it's always going to be functioning. You can have an adenoma that is non-functioning. And in fact, with an adenoma, let it be micro or macro adenoma, you really, really want to pay attention to the clinical picture. And by that I mean the following. Microadenomas, granted, tend to be functioning, that we talked about earlier. In microadenoma, if we're talking about functioning, prolactin might be the most common hormone to then be secreted. If it's macroadenoma, these then tend to be non-functioning. And if it's non-functioning, may result in hypopituitarism. However, even with macroadenomas, you could have a secreting tumor such as a growth hormone macroadenoma. Is that clear? So we talked about this earlier in endocrinology. I'm bringing this to your attention once again. the first thing that you always ask yourself, is my adenoma functioning or not? And as soon as you have something like a macroadenoma that's non-functioning, every single hormone will be compromised from the pituitary except prolactin. Why? Because this large adenoma might then compress the stalk. If you compress the stalk, you're not able to deliver the dopamine, and thus you increase the release of prolactin. I'm not going to review that. At this point, you should be well versed with the effect of dopamine, influence of dopamine on prolactin. Most common hyperfunctioning presentation would be excess prolactin, as we talked about. So therefore, this female, if she has a functioning prolactinoma, she's going to present with the galacturia. And you know from feedback mechanism that prolactin inhibits your GnRH, doesn't it? And so therefore, if prolactin inhibits GnRH, she is then going to present with amenorrhea and decreased libido. Treatment, obviously surgical. You get in there and try to remove the prolactinoma. However, with the prolactinoma, you know that you can use a dopamine agonist to either be bromocriptine or carbagelin. These are dopamine agonists to then halt or control the amount of prolactin being secreted. Here we'll take a look at acoustic neuroma. So what does an acoustic neuroma mean to you? As soon as you hear acoustics, you're thinking about what? Oh yeah, hearing. And as soon as you hear about hearing, then you should be thinking about what cranial nerve? Eighth, right? Vestibulocochlear. It's not a primary brain tumor. Schwannoma of the vestibular branches of the eighth cranial nerve. Stop there and make sure, whenever you hear the word or description acoustic neuroma, you should be thinking about the cerebellopontine angle, and here you have your bilateral schwannomas. And a bilateral schwannoma, in general, would then come from what's known as a preceding event, and that's called neurofibromatosis type 2. I'll talk a little bit more in a second. At this point, acoustic, automatically, cranial nerve 8, automatically thinking vestibular branch of the 8th cranial nerve. In terms of location, you're at the cerebellopontine angle. The most common tumor of the cerebellopontine angle, and here once again, in meningioma, perhaps number 2. Benign tumor, surgical resection is curative treatment, often presents with unilateral tinnitus or hearing loss. Now be careful with that one. So up until this point, I've been telling you that it could be, in fact, commonly, it's bilateral. Not always. Symptoms could be unilateral if you're affecting the vestibular. So look for hearing issues or tinnitus. In terms of an acoustic neuroma and where it's arising from, how many ears do you have? 1, 2. Okay. So therefore, an acoustic neuroma would arise from neurofibromatosis type 2. A type 2 neurofibromatosis would give rise to an acoustic neuroma, aka a schwannoma. Now, what I'm not going to describe to you, but you want to keep in mind, is that if at some point in time you hear about neurofibromatosis type 1, then you're thinking about giving rise to your neurofibroma. With neurofibromatosis type 2, this is then referred to as being your Merlin.